So let us start our journey, and that is about non-catecholamine drugs. So direct acting drugs we are discussing. In direct acting, what we are going to discuss is non-catecholamines. Okay, sir. Now let us go in the receptor manner. Let us take beta. Do we have any drug which is a beta 1 agonist? In beta 1 agonist, we have a drug which is still in investigation, that is called prenalterol. It is called prenalterol. It is an investigational drug. It's not still approved. It is being investigated for beta blocker toxicity and other conditions. So right now it is investigated for beta blocker toxicity, but still not approved, so we are not worried about that. One more drug which is a beta 1 agonist, but it's a catecholamine, is dobutamine. It is dobutamine. Don't confuse with dopamine. It is dobutamine, beta 1 action only. Dobutamine doesn't have action on dopamine receptor at all. Then the beta 2 agonist drugs. The beta 2 agonist drugs which are used because beta 2 can cause bronchodilation, and since they cause bronchodilation, these drugs are used in bronchial asthma and COPD. So what are these drugs called as? The drugs are called as salbutamol, and one more drug is called terbutaline. And the longer acting drugs are salmeterol, and one more is formoterol. So we'll discuss them in detail when we come to asthma. Then one more beta 2 agonist, what we have is the uterine relaxants. Uterine relaxants are also called as tocolytics. Now, where do you want to relax the uterus? Obviously, when there is preterm delivery, that means delivery occurs before the term, the baby is not matured, lungs are not matured. Or if you are doing some obstetric procedures, then you have to relax or threaten abortion. So the drugs are same drugs like salbutamol, terbutaline are used, but the specific drugs which are used in uterine relaxation are ritodrine and isoxaprine. So again, we will discuss this in endocrine, don't worry. Then we have a drug called clenbuterol. It is called clenbuterol. This question had been asked recently. It is an anabolic agent. So it's an anabolic agent. That means it is going to build the body. So athletes can take this and they can run, but it is banned from using in athletics. So clenbuterol is an anabolic agent which can enhance the performance by increasing the body. So recently this question had been appeared, clenbuterol. It's a beta 2 agonist, but along with that it has anabolic property. Then we have the beta 3 agonist, specifically beta 3 agonist, and the name is called mirabegron. It is called as mirabegron. One more which ends with begron is vibegron. So remember B for bladder, begrons. Now where is beta 3 located? One is in adipose tissue, correct? One is in detrosar. If I stimulate beta 3, detrosar will contract or relax? It will relax. What happens if it relaxes? Urine will not come out. Urine gets retained. So which condition you want to retain? Urine. These are used for condition called overactive bladder. They are used in overactive bladder. So the name is mirabegron and vibegron. Yes. So that is about the beta 1 agonist, still investigational, but remember mainly the beta 2 agonist and beta 3 agonist. Clenbuterol was asked, mirabegron repeatedly asked in your exams. Again, please mark this question. So begron for bladder. So mira bladder. Now move on to the alpha. So first we'll take up alpha. In alpha, first we'll take up alpha 1 agonist drugs. In alpha 1 agonistic drug, The first drug what we are going to discuss is one of the beautiful drug by the name phenylephrine. So phenylephrine is alpha 1 agonist. Now this drug is been used in three important conditions. Three important conditions, very, very important. Now it can be used as eye drop. Now where do you use this eye drop? It is an eye drop to produce what? Active mydriasis. So it is an active mydriatic. Now why do you want to cause mydriasis? Why do you want to use it? For fundoscopy and during adhesions. If there are adhesions inside the eye, what we do, we give miotic and mydriatic alternatively. Then we use the mydriatic, that is phenylephrine. Second one is during fundoscopic examination, phenylephrine. Now the second important use is it is used intravenous. Now where do you use it intravenous? We use it in the management of hypotension. We use it in the management of hypotension. It is one of the beautiful drug for hypertension because it acts on alpha 1 and increases the BP. Another important use of the drug, we give it orally also. Now orally, where do you use it? Orally, the drug is used as nasal decongestant. Nasal decongestant. Now what do you mean by nasal decongestant? In the nose, when the blood vessels are dilated, the water will come, what we call as running nose. So if I use a vasoconstrictor that will constrict the blood vessel, the running nose stops. So that's the reason why it is called nasal decongestant. Now I will do one thing. I will discuss the drugs used in hypertension. Let us discuss the drugs used in hypertension. Let me write them. Hypotension drugs. In hypertension, I told you the direct acting drug that is used is phenylephrine. The name is called phenylephrine. One more is called methoxamine. One more is called methoxamine. Okay, so direct acting drugs, we have two drugs, phenylephrine, alpha 1 agonist. Methoxamine is a alpha 1 agonist that is also used. Then we have mixed acting drug. Yes, you tell me what are the mixed acting drugs? They are called ephedrine. And one more, mephenteramine. Mephenteramine. These are the things. Then once you know the mixed acting, there are drugs which are used only for severe hypertension. So they are non-specific drugs. They don't work on alpha only, but they are for severe hypertension. The name is noradrenaline. So noradrenaline is used in shock with hypertension, and one more drug is dopamine. So when we use dopamine, there is a risk of arrhythmia. So severe hypertension, we use noradrenaline and dopamine. Otherwise, commonly used drug for hypertension is phenylephrine. Phenylephrine. For hypertension, we have direct acting drug that is phenylephrine and methoxamine, mixed acting ephedrine and mephenteramine. The drugs which are non-specific and they are only for severe hypertension are noradrenaline and dopamine. And the most commonly used drug is phenylephrine. So once we know the drugs used in hypertension, I just want to discuss the drugs which act on alpha, which are used for a condition called orthostatic hypotension. These drugs are used in orthostatic hypotension or dysautonomia. Now, what do you mean by dysautonomia? The autonomic nervous system is not working properly. What happens when you are lying down and suddenly get up? When you suddenly get up, the reflex mechanism is to constrict the blood vessels, that is veins, and the blood comes to the heart and the BP is maintained. But in some people, that phenomenon will not work out. So when they suddenly get up, the veins will not constrict, the BP falls, and they have hypotension. That is called postural hypertension or orthostatic hypertension. So that may be a problem because the autonomic nervous system is not working, and that is called dysautonomia. Now, for these patients, we have drugs approved for that. What are the drugs for these conditions? So the drug name is midodrine. The name is midodrine. And one more is called droxidopa. So one is called midodrine and one is called droxidopa. Remember, midodrine and droxidopa both are prodrugs. Both are prodrugs. And that means they will become active. So midodrine will become active, that is called desglymidodrine. Droxidopa will become noradrenaline, and that will act on alpha 1. This will act on alpha 1 and increase the BP. So the problem here is hypotension, and they will work. Here in general pharmacology, you told us that prodrugs are not used in emergency. And then why are you using it? Please understand, orthostatic hypotension is not an emergency. Only when the patient gets up suddenly from sitting or from sleeping, then only problem. If the patient doesn't do that, no problem. So it's not an emergency. That's why we give a prodrug like midodrine and droxidopa for managing orthostatic hypotension or dysautonomia. Their prodrug become active and they cause alpha 1 agonism and increase the BP. So whenever the person gets up, they will have alpha 1 action, constrict the veins and maintain the BP. So that is about the drugs for orthostatic hypotension, the other drugs for hypertension, and let us discuss the nasal decongestants. Very, very important. So let us discuss the nasal decongestants. So nasal decongestants are the drug used for common cold. So in common cold, there is running nose. Remember, running nose doesn't mean that nose runs. If you run, nose also will run. The secretion is running because there is vasodilation. So the drugs used are called as nasal decongestants. What are the drug name? Drug can be given two ways. Either you can give topical or you can give systemic. So nasal decongestants can be given in two ways. Either you can give topical or you can give systemic. The topical one is oxymetazoline, then xylometazoline. Xylometazoline, they are given as topical, and nafazoline. These are topical drugs. Systemic drugs are like this. Phenylephrine. So phenylephrine usually is given in pediatric formulations as nasal decongestant. And another drug, pseudoephedrine, it is given as tablet along with cetirizine. It is given. So it is usually given as drops or syrups in children. And this is given as tablet. Earlier, we had a drug by the name phenylpropanolamine. It is called phenylpropanolamine, and that used to cause stroke. And now it is been banned. It is called phenylpropanolamine. Why? Because it enters the brain and causes vasoconstriction, and it may lead to stroke. Many times what happens, these people abuse these drugs. They keep on taking the topical drugs again and again whenever they have common cold. So if that is being asked, what happens if it is being used repeatedly? It will cause atrophic rhinitis. Now why atrophic rhinitis? Because these are vasoconstrictor. They constrict the mucosa. So the nasal mucosa will become atrophied. And this problem is called rhinitis medicamentosa. So they should not use it regularly. So once in a while, no problem. But if they use regularly, it can lead to atrophic rhinitis. And that condition is called rhinitis medicamentosa. You have to advise this patient. So when you are prescribing, tell the patient it should be used whenever necessary, not every day. So that is about nasal decongestant. Remember, all these nasal decongestants, they mainly act on alpha 1 receptor and alpha 2 receptor present in the nasal mucosa. Orthostatic hypertension also, all the drugs act on alpha 1. And coming back to the drugs used in hypertension, they are also acting on alpha 1 and increase the total peripheral resistance and increase the BP. Right, so that is about the drugs which are mainly the alpha 1 agonist, which are very, very important, and we have discussed them in detail. So, the alpha 1 stimulators. Main drug you remember is phenylephrine. Let us move on and discuss another important aspect, the alpha 2 agonist. The alpha 2 agonist. Now, where is alpha 2 located? We all know that alpha 2 is present mainly presynaptically. Now, it decreases Norlin and decreases the BP. So, let us discuss the drugs. So, before that, let me tell you, this is the synapse. This is the location of alpha 2. So, if you give alpha 2 agonist, what happens? It decreases noradrenaline release. That means it decreases the sympathetic output. So, what happens to the BP? The BP decreases. Patient will be having sedation. Yes, so that is a specialty of alpha 2 agonist. Okay, let us discuss the drugs here. The first drug in alpha 2 agonist is a drug by the name dexmedetomidine. So it looks like meditation. Dexmedetomidine looks like meditation, so we use it in ICU sedation. Suppose you want to sedate a person in ICU, then you can use dexmedetomidine, and also it is used as pre-anesthetic medication to calm down the person. You can use that as pre-anesthetic medication. You can see why sedation, because they decrease the sympathetic surge. Clear. The second drug is called clonidine. Clonidine I have discussed in detail in antihypertensive therapy. I'm just going to touch up here. Clonidine, it decreases Norlin release, so it is used to treat hypertension. It is also used in menopausal, hot flush, and it is also used in diarrhea in diabetes patients. It is also used in diarrhea in diabetic patients. That is the use of clonidine. So clonidine is used in hypertension, menopausal, hot flush, diarrhea in diabetics, and one more condition it is used is in tics disorder. So it is also called as Gilardi-Tourette syndrome. So the impulse is coming from the CNS, and that can be suppressed with the use of clonidine. Many times the question is asked, when you give clonidine, there is initial increase in BP followed by decrease in BP. So why it is like that? Now the alpha receptors are two important types I have explained here. Alpha receptors, that is alpha 2 receptors, are two types, alpha 2A and alpha 2B. Now alpha 2A is the one which is present in the presynaptic terminal. This is the point. So this is present here. And alpha 2B is the one which is present as the B suggests blood vessel. Now you know that when we give clonidine reaches the blood vessel. So when it reaches the blood vessel, the major action is on alpha 2. And you know that alpha causes vasoconstriction and there is increase in blood pressure, that is only mild. But later what happens? From the blood vessel it reaches the CNS and it acts on alpha 2A and decreases the Norlin release, and that will lead to decrease in BP, and that is a major effect what we see. So many times this question, many students ask this, so that's why I'm explaining the mechanism, how it is going to work. Second question asked is, sir, how come it is useful in diarrhea? Now, this is the parasympathetic nerve, not sympathetic, parasympathetic nerve, and this is the acetylcholine. You know that acetylcholine gets released, act on the postsynaptic terminal, that is M3. It increases the motility of the intestine. And it also increases secretion, because you know that parasympathetic means secretions. Now, this acetylcholine is also controlled by alpha 2. So, there is a alpha 2 and this is called heteroreceptor. It is called as heteroreceptor. What do you mean by heteroreceptor? Which is present in other system. Suppose if I take the example of sympathetic, so this is the sympathetic system, and if you see alpha 2 here, that is called autoreceptor. But if it is present in other system, parasympathetic, it is called hetero. And we know that alpha 2 is GA coupled receptor. What happens? It will not allow the acetylcholine to get released. So there is decrease in motility and decrease in secretions. So that is the reason why it can be used in patient with diabetes, diarrhea. Because in diarrhea, there will be increased motility and increased secretion. That's the reason why it is used clonidine. So these are the explanations for that. So we are discussing the alpha 2 agonist, that is clonidine. Similar to that, we have another drug, the alpha 2 agonist drug, and that is called alpha methyl dopa. Alpha methyl dopa is converted into alpha methyl dopamine. So you remember the flow chart which you are given. Dopa becomes dopamine, and from that what we get is alpha methyl noradrenaline. So same enzymes are involved. To convert alpha methyl dopa, we require the enzyme decarboxylase, and to convert this we require hydroxylase. So the active form is alpha methyl norepinephrine, and this is a prodrug. This is a prodrug. Now this is going to act on alpha 2 and decrease the BP. So this is the mechanism of action in detail. This alpha methyl dopa, it is used to treat hypertension in pregnancy. Alpha methyl dopa is safe. We can use it in hypertension in pregnancy. The name, simply we call it as methyl dopa. Similar to clonidine, we had earlier drugs. The name is called guanfacine. So guanfacine now is used in a condition called tics disorder. Tics disorder, along with the patient has ADHD, then the best drugs are guanfacine. One more drug which can be used to control both ADHD as well as tics disorder. The name is called clonidine. So clonidine and guanfacine can be used for a patient with tics disorder with ADHD. Okay, so that's the importance of guanfacine, which can be used for tics disorder with ADHD. These are best drugs. Similar to another one which starts with the same, it is called guanabens. So these are also alpha 2 agonist. So in alpha 2 agonist, we have discussed dexmedetomidine, clonidine, methyl dopa, guanfacine, and guanabens. Guanfacine ends with face. So remember face. What is tics disorder? Patient will be frowning or doing lip smacking like this, or will be winking like this. So that is the tics disorder. Sometimes there may be vocal tics, and we call it as Guillain-Barré. So tics disorder, these are used. Along with ADHD is also there, then these are the best. The other alpha 2 agonist is by the name lofexidine. The name is lofexidine, and it is used to treat opioid withdrawal symptoms. Now, when you are using opioids, your sympathetic system is blocked. Sympathetic surge is decreased. So when you suddenly stop opioid, sympathetic will come out. So the drug which is used to block that is lofexidine, decreases sympathetic surge. One more drug is by the name tizanidine. Tizanidine, it is used as centrally acting skeletal muscle relaxant. So where do you use centrally acting skeletal muscle relaxant? They are used in muscle spasm. Suddenly you are running and muscle catches. Then what we use is called tizanidine. Then we have alpha 2 agonist. So when we have alpha 2 agonist, the name is called pracolidine, and one more is called brimonidine. You know that alpha 2 agonist, what I am talking, is in the eye. So in the eye, they decrease aqueous humor. So when we use them locally, this alpha 2 agonist, which is apracnidine and brimonidine, they are used as eye drops for glaucoma. In the management of glaucoma, the drug name is apracnidine and brimonidine. So remember, most of the drug names end with nidine, tizanidine, lofexidine, right? So let me repeat again: dexmedetomidine, clonidine, methyl-dopa, guanfacine, guanbenz. Then we have tizanidine, lofexidine, and apracnidine and brimonidine. I have told you the indications of these drugs. Moving on to other drugs which are non-catecholamines but used in other conditions. So let us discuss the other drugs here. Let us discuss the other drugs here. The drugs for ADHD. Drugs for attention deficit hyperactivity disorder. We discussed in the beginning that sympathetic can increase the attention span. So what are the drugs we use for this? In ADHD, we use the drugs called methylphenidate. So methylphenidate is a derivative of amphetamine and it is considered the first choice of drug here. Again, we have a drug called pimolin that is also used for this. And then we have a drug called atomoxetine. Atomoxetine is known to inhibit the reuptake of noradrenaline. So remember, all these drugs what we are discussing, they are all going to increase the sympathetic activity. If you increase sympathetic activity, the attention span increases. Now the amphetamine group example is lisdexamfetamine, and one more is dextroamphetamine. So these are the drugs used for ADHD. So you know the mechanism of action of amphetamine and all these things. Methylphenidate, pimolin, atomoxetine, lisdexamfetamine, dextroamphetamine. These are all the drugs for attention deficit hyperactivity disorder. And the drug of choice will be methylphenidate. Okay. Now we discussed the drug by the name amphetamine. Now amphetamine usually we avoid in therapeutic use because it is a drug of abuse. It is used in parties. A derivative of amphetamine is called MDMA. It is called ecstasy. It is used in rave parties. So these are a drug of high abuse potential. So we are not using them in the treatment. We are not using them in management of these patients. Okay, so another drug what we are going to discuss is by the name modafinil. The drug name is modafinil. Modafinil is a drug which is used to treat narcolepsy. Now, what do you mean by narcolepsy? It is a excessive daytime sleepiness. So they may sleep suddenly. Suppose they are driving a car, suddenly they may sleep. So to make them alert, the drug that is used is modafinil. Modafinil is used one more condition, that is as an adjunctive drug for a condition obstructive sleep apnea. So modafinil is used as an adjunctive drug in obstructive sleep apnea. So in this obstructive sleep apnea, patients are obese, the tongue may fall back and they will be keep on getting up in bed. So due to that, morning they will have so much of sleepiness. So then we use the drug modafinil. Modafinil is also used when there is jet lag. So they have jet lag and morning they have to attend a meeting. Then modafinil can be used. So narcolepsy, obstructive sleep apnea and jet lag. Sir, are there any other drugs for narcolepsy? Yes. For narcolepsy, we have another drug. The name is called tiprolisant. Tiprolisant is not a sympathetic drug, but since I am discussing the drugs for narcolepsy, I will tell you it's a H3 inverse agonist. It's a H3 inverse agonist. It is also called by one more name, pitolisant. So it is called by one more name, and that is called pitolisant. For narcolepsy, we have recently one more drug that is called solriamfetol. The name is called solriamfetol. The name is called solriamfetol. It is called as NDRI. So what is NDRI? N for Norlin, D for dopamine reuptake inhibitor. The name is called solriamfetol. So for narcolepsy, we have modafinil, solriamfetol, tiprolizine, also called as pitolisine. But if they ask you what is the drug of choice, narcolepsy, the drug of choice will be modafinil. The best drug is modafinil. Now recently, there is a drug called dextroamphetamine. Dextroamphetamine. This drug is used for ADHD as well as narcolepsy. So these are the drugs which are used for CNS conditions. That is to increase the attention span and to make the patient alert. So dextroamphetamine is approved for ADHD as well as narcolepsy. So these are the options what we have. Amphetamine, MDMA, they are all drug of abuse. And drugs for ADHD, methylphenidate, pimolin, atomoxetine, lisdexamfetamine, dextroamphetamine. There is something called methamphetamine that is also drug of abuse. We don't use it for therapy, right? So these are the drugs which are used in the CNS conditions. That is sympathetic in origin. Moving on to the last concept in sympathetic drugs. I told you sympathetic stimulation can cause anorexia. There are drugs which are called as anorectic agents. So sympathetic drugs which are called as anorectic agents which cause anorexia, and they are used to treat obesity. They are used to treat obesity. So what are the drugs here? The drugs which increase serotonin, 5-HT serotonin, and increase noradrenaline, and the drug name is called sibutramine. The name is called sibutramine. Drug which increases only serotonin, and the name is called fenfluramine. It is called as fenfluramine. And the drug which increases only neuronal activity, and that is called phentermine. Phentermine. So these are the drugs which are used in the management of obesity, and they are sympathetic in origin. They are sympathetic drug, but the first two drugs are banned. The reason why they are banned, because they are shown to increase cardiovascular deaths. The only drug which is now used is phentermine. The only drug that is used is phentermine. So once we are discussing the anoretic agents, it's important that we discuss drugs for obesity. Very, very important, and every year the question comes. So let us discuss the drugs for obesity. What are the drugs? The drugs for obesity: cooking medium. So usually we use sunflower oil or the coconut oil like that. But the safest one we have is called Olestra. The cooking medium can be used in people with obesity. Then we have a lipase inhibitor. The inhibitor of lipase, the name is called orlistat. Remember, if the drugs usually end with stat, they are enzyme inhibitors. If they end with ASC, they themselves are drugs which are enzymes. If they end with ASC, for example, asparginase, like that, rasbericase, they are all enzymes. If they end with stat, they inhibit the enzyme. For here, they inhibit the enzyme lipase. Now, what happens if you inhibit the enzyme lipase in the gut? The fat is not metabolized, so patient will have adverse effect, that is loss of fat in the stool. So that is called steatorrhea. So this question was asked. Then we had a drug called rimonabant. Rimonabant was a stimulator of cannabinoid receptor. Now it is being banned, so I am not telling that. The drug was rimonabant. So that was used. So the cooking media is called Olestra. Lipase inhibitor is called orlistat, and the adverse effect is steatorrhea. Now apart from that, there are some older drug, and the name is called cannabinoid 1 receptor antagonist. Now remember, cannabinoids are going to increase the appetite. Cannabinoids are going to increase the appetite. If you block that, there is decrease in appetite. So the drug, the name of the drug is called rimonabant. Rimonabant is not used nowadays, it has been banned, but sometimes it may be asked as a question mark. Then we have something called endogenous slimming peptide. So endogenous slimming peptide, it's still under research, and that is called leptin. So we are trying to get the drugs which can stimulate this. Still, we are not able to get that. Then we have a diabetic drug, they are called GLP-1 receptor agonist. Now this is a favorite for examiner. Please mark this. They are called as liraglutide. Liraglutide and one more drug recently approved, semaglutide. These are favorite for examiner. Please mark it. One more drug is 5-HT2C agonist, and the name is called lorcaserin. You read the name, L for lowers, O for obesity, serin for serotonin. 5-HT means serotonin. It is also banned. The reason is it has shown to increase the risk of cancer. Increase cancers. Okay. So that's the reason why liraglutide and semaglutide are asked repeatedly. Then the combinations of drugs are also being tried. Combination drugs. What are the combination drugs used for obesity? The combination is bupropion plus naltrexone. Bupropion plus zonisamide. And phentermine plus topiramate. Phentermine plus topiramate. These are the drugs for obesity. And every year, one or the other question comes from this. That's why we had to go in detail for drugs for obesity. We discussed the sympathetic drugs, what act on CNS, the concept of amphetamine, then the alpha 2 agonist, then alpha 1 agonist. Then we discussed the drugs for hypertension, nasal decongestants, and the beta 3 agonist, beta 2 agonist, beta 1 agonist. These are all direct acting non-catecholamines. Catecholamines, I went in detail and told you the main drugs: adrenaline, noradrenaline, dopamine, dobutamine, isoprenaline, dopexamine, phenoldiazepam. Very, very important. Please, you have to go with that. So, the basics for understanding systemic pharmacology comes from the ANS. So, ANS is the backbone for understanding all these things. Okay, so the variation in BP, the graph, we have done a separate video where you can see that. So until now, whatever the information has been given here, the concept, what you have understood, has been repeatedly tested in your exam. So you can see the adrenaline, the graphs for adrenaline. Then you can see the isoprenaline concept. Then dopexamine, dobutamine, dopamine, phenoldiazepam. Now, what do you mean by catecholamines, non-catecholamines? What do you mean by direct acting, mixed acting, indirect acting? We discussed that. Then we also discussed the receptor location and what do they do, beta 1, beta 2, beta 3, then alpha 1, alpha 2. And then we also discussed the receptor locations and what type of receptor are they. Then we discussed the neurotransmission and what drugs inhibit that. So we started our journey with understanding the adrenergic drugs. So this is where we started. Right? So please understand the concept, read in a conceptual manner. If you know this, because if I take RS, again you will come to salbutamol, salmeterol again. If I take GAT, again the drugs will come. If you take CVS, again the drugs will come. CNS, again the concept will come. So that's why this system is the basis to understand the future of pharmacology. So with that, we'll end up the adrenaline system. Thank you all.